Yes, doctor, we are live now.
Good evening, everyone. We are Young Ophthalmic Society of India, the Medicolegal. So we welcome you again to another session of medical issues. So we have already covered multiple sessions which are available in YouTube, and today we'll be discussing patient confidentiality and its medical legal aspects. So our panelists are Anand Deshpande sir, who has been guiding us since the beginning. Sir is a director and eye surgeon at Guru Prasad Netra Rugnalaya, Aurangabad. Sir is the chairman of Indian Medicolegal Consulting Service Private Limited. Sir is also the chairman of Medicolegal Committee of All India Ophthalmic Society. Sir is a faculty member of law and a visiting professor at Symbiosis Law College, Pune, National Law University, Aurangabad, and Faculty of Management Sciences, BAMU, Aurangabad. Sir has written various books, including the Consents, which has been published by YOSI. We are also privileged to have Manoj Mathur sir, who also has been our guide since the beginning. Sir is a senior consultant in glaucoma and comprehensive ophthalmology at Swarup Eye Center, Hyderabad. Sir is presently the honorary treasurer of AIOS. Sir has been past advisor and president of Telangana Ophthalmology Society and Hyderabad Ophthalmologist Association. Sir is the co-chair of Health Insurance and TPA Committee of AIOS. Sir has been a member of Medical Legal and Ethics Committee of AIOS in the past. Sir has been twice a member of the management committee of AIOS. Welcome, sir. We are privileged to have our guide, Dr. Prakash Marathe sir, with us. Sir has been a past president of Indian Medical Association, Pune, Maharashtra Ophthalmical Society, and Pune Ophthalmical Society. Sir was past senior vice president of IMA Maharashtra State. Sir has been involved in multiple activities of IMA Pune, and Sir received President's Appreciation Award by National IMA Headquarters, New Delhi. Sir received President's Appreciation Award by IMA Maharashtra multiple times. Sir has received multiple awards. Thank you, sir, for guiding us.
Thank you. Thank you so much.
Thank you, sir. We are privileged to have Anand Vinekar sir with us. Sir is the head of the Department of Pediatric Retina of Narayana Netralaya, Bangalore. Sir is the program director of TID-ROP, which is the tele-ROP program by Government of India and which has been a huge success and a role model. Sir is the advisor of infant blindness prevention of Government of Karnataka. Sir is a member of Task Force of Retinopathy of Prematurity of Government of India. Sir is the founder secretary of Indian Retinopathy of Prematurity Society. Sir is a technical member of Queen's Diamond Jubilee Trust for ROP of United Kingdom. Sir is a member of International Council of Ophthalmology ROP Guidelines. Sir is a member of IMA Committee for Infant Blindness Prevention. Sir is a member of ICROP 3, which published the recent ROP classification. Sir is was the organizing secretary of 5th World Retinopathy of Prematurity Congress in 2022. And Sir did his MBBS from St. John's Medical College, Bangalore. Sir did his MS and senior residency from PGI, Chandigarh. And Sir won the Kataria Gold Medal from Prime Minister of India. Sir has done fellowship in pediatric retina, and Sir has also PG DMLE degree. Sir has also done PhD. Sir has multiple publications and one textbook. Sir has given 4 Orasan Awards and over 235 invited talks. Sir has received multiple awards, including Colonel Rangachari Award. And Sir was named among the top 2% of all scientists of Stanford. Thank you, sir, for joining us.
I think a lot of Sir's publication we use commonly for ROP citation,
Yes.
actually. Many of them, actually.
Dipanshu and Dr. Kaushik for that introduction. And my greetings to Marathe sir and Mathur sir. Looking forward to learning from you all. Shall I share my presentation?
Yes, sir.
Please, sir.
So, is it visible?
Yes, sir.
Oh, right. Okay, great. So today I think we're going to talk about a very interesting topic of patient confidentiality and its medical legal aspects. So firstly, I may have done a postgraduate diploma in medical law and ethics, but this is certainly not legal advice. I think we are just here to share experiences and learn from the judgments and the cases that have happened in our country and from seniors who are on the panel today. Why is, first of all, confidentiality an issue? And why has it become even more important now than maybe 2 decades back? Because I think the whole system of how we practice medicine has changed. So in the good old days, there used to be a single doctor-patient relationship. Perhaps we always visited, there was home visits. There was just one caregiver and one patient. And mostly the doctor relied on their clinical acumen with very little dependence on technology. But we know today that's not the case. Today there are, modern medicine has become complicated and in some ways perhaps sophisticated as well. But there's a lot of dependence on technology, which means there are a lot of reports that are going to come out, and more so, a lot of multiple caregiver levels that are going to come out. Rather than you and the patient 30 years ago, today you have the shared care of multiple caregivers. And this now gets regulated both from an ethical standard and from a legal standard. Now look at this very complex chart of how the Indian healthcare system is. So of course, we know there is in general a public sector and a private sector, but even under that, even if you just look at allopathy and not even the other Ayush specialties, there is a whole lot of categorization. And each one of these hierarchies invite certain amount of regulations, and also the levels of entry of these patients and its escalation there upwards will cause this multi-tiered system to have complications in terms of sharing information of the patient as they go either up the tier or come down. The next big thing that we know that happens in private sector, but also in government sector like Ayushman Bharat and RBSK, is the whole insurance compulsions. So in some way, the insurance companies want to know what diseases there are because there will be claims made. And on the other hand, we as doctors who have that privileged information are expected to share some and maybe not. And where do we stand, therefore, in the current context of medico-legal problems? To understand confidentiality, we need to go back to the basic and understand what is privacy. The dictionary definition of confidentiality and the legal definition are slightly different, but one comes from the other. So, and the Oxford English Dictionary says that it is basically to be left alone, to be not observed or disturbed by others. And I think that's fairly easy to understand. From a legal perspective, about 20, 30 years back, there have been some seminal judgments. We'll go over some of them that are relevant to today's discussion. But probably the very first one that even made a mention was this, the Rajgopal versus State of Tamil Nadu, which added under its ambit home, family, marriage, motherhood, procreation, and child rearing. As ophthalmologists, we may not encounter all of them, but I think we need to be aware because the principles that fall on those will also apply to us in our field. And of course, if we are sharing the care with other subspecialties like neonatology or psychiatry or immunology, then of course, all of these will come under our purview as well. Historically, the most dominant article has been the Harvard Law Review in 1890, where these two gentlemen, one of them went on to become a Supreme Court judge in the US, made it very simple. They said privacy is basically the right to be left alone. And this was being discussed in an era where the print media had come in and there was a lot of possible defamation and a lot of breach of privacy, as we call it now. But what's it in the Indian scenario? So privacy is basically, when you're talking about legal remedies, you're talking about your privacy being breached, either by the state, which is basically the government, where our rights are protected under the fundamental rights, or non-state agencies, which is basically you against me or anyone against anyone else. So where do the state agencies come? I think this is the Karak Singh versus State of Uttar Pradesh case, where just because someone had a history of being a thief was constantly put under surveillance, and then that was found to be, a breach of privacy, because you can't constantly assume that he is always the quote-unquote history sheeter. The other case was the Neera Mathur case, who was sacked from her job because they found out later that she was pregnant at the time of her interview and she did not reveal it. And then they said that she has her right to protect that autonomy that she was, carrying, and that need not have influenced either the decision to hire her or to fire her. So basically, all of these cases brought the right of privacy under the very important article of Article 21, which is right to life. And for all of those who know a little bit of the Constitution, Article 21 is the pillar, is really the cornerstone of our fundamental rights. So it's given that status in the Constitution. And then you have the People Union Civil Liberties case and the Narayan versus State of Maharashtra case. But perhaps the defining case that almost all of us will know is the Justice K. Putswamy case. And basically, this was a case looking at the legal validity of the Aadhaar system. But what it ended up doing, and this, remember, is a 9-member bench, which is very high. It's like almost a constitutional bench or more. And they were examining whether Aadhaar was valid or not. And then they looked at privacy, because that was really where these issues were leading. And then they found that privacy must be protected and it's intrinsic. And this is the one case that actually put it down, saying that it is under the right of liberty and personal and right to life. So that was the state. That is when, the government infringes your fundamental right and therefore possibly confidentiality as well. But we'll take these learnings into medical confidentiality soon. But before that, non-state agencies are much easier to understand. And that's the law of torts, as they say. Something went wrong and you are looking for a legal remedy. But what's important here on the right side of your slide are the fact that now privacy has got a mandate to be protected under big declarations and big rights like the EU Charter, the Convention of Rights of the Child, and even the Universal Declaration of the Human Rights under the WHO. To understand the subtle difference between privacy and confidentiality, the best example is probably an app. We keep downloading apps on our phone, and a lot of time we give a lot of information. It's not that we are giving it without knowing. We are voluntarily giving information. So in that respect, they have taken your consent to get your information. But somewhere down that agreement that we often don't just read and we agree to everything, it will possibly say who they can divulge that information to. And that's where the breach can come. So privacy is your information that should be remaining with you, and confidentiality is divulging that information to someone else whom you may not have authorized. So there's this difference. They are linked, but they are different legally. And what about medical or patient confidentiality? Obviously, it means that it is defined where a doctor or a medical practitioner cannot reveal anything. And I think the two words important here are during consultation and during treatment. Why is confidentiality important? Because at the end of the day, forget this slide, at the end of the day, it means that if a patient will not trust you to keep his or her information with you, then he's not going to tell you all those things that you might require to heal him or her. And if that happens, you're not going to be doing your best job as a physician, and the patient is not going to have the best outcome because the symptoms have probably not even been expressed. So at the end of the day, if the doctor-patient relationship has to flourish and both parties have to do well in their roles, confidentiality then becomes very important because one leads to the other. Now, and we refer to this in the second slide, that today we have to share the care with so many verticals in our healthcare pillars. Be like, an orthopedic surgeon has to look after with physiotherapists or paramedics. In a large tertiary care hospital, you're doing cross consultation with so many departments. The question is today, information that you have based on your organ specific disease, in our case, ophthalmology, can you and how much should you give out that information to another vertical who may or may not be related? Diabetic retinopathy, diet to a dietitian, syphilitic retinitis, sexual transmitted disease to the physician. So you are privy to information that potentially has to go through many verticals, and what is the legal mandate here? So I think just like we saw the United Nations Declaration, we have all of this: Hippocratic Oath, Declaration of the Geneva, the NMC, which is, I think, the very important document for all of us, and biomedical research itself. I brought this here because, the doctors who took care of Sushant Singh Rajput's medical care had made sure that they had kept his confidentiality. And if you go back to the previous slide, the Declaration of Geneva says that we are mandated to keep private even after the patient's death. So, and I thought this example was important. We also have the revised Hippocratic Oath for the Indian medical students, although this is not as mandated, but it's a good idea for us to know that I shall respect the secrets, I'll take into confidence the family for the purpose of best treatment of the patient. So at the end of the day, it's the patient interest that's most important. And when I'm required to divulge by law, I will do to make sure that my patient's interests are protected. And if we are faced with a dilemma, or should I divulge or not, if you just go back to these three pillars, saying what should I do, what are the limitations, and what is my best interest at heart, we'll be guided the correct way. And a patient, and this line in yellow basically is the rationale that if they will not divulge to you if they don't trust you. So a doctor-patient relationship is built on trust. Confidence is lost if that trust is lost. Trust is lost if confidentiality is lost. So the three pillars, and this is 1965 in medical ethics, is firstly the patient's autonomy to take care, to decide about his body condition and his body reports, your integrity as a healthcare provider, and that equation that will define your doctor-patient relationship. But is this sacrosanct? Is this right or duty absolute? No, certainly not. There are exceptions to this right to confidentiality, and we know some of them. And I just put out this newspaper cutting to show you that, and I think the best example was during COVID time when so much had to be divulged. But let's go back to tuberculosis. So the fact that if you don't divulge, you are actually violating laws, and this is before the new BNS. So there are sections under the IPC that you could be held liable, violating if you had not expressed the fact that this patient had a communicable disease. So again, what is the rationale for any of these exceptions? That it allows the patient to get better support. Now, a tuberculosis patient, if you don't declare to the relatives, the idea is that that patient may not be compliant to take the anti-tubercular therapy. And if you don't then inform the next of kin or the public, that person could spread the disease, especially in an infectious disease. So in India, we don't have, it is assumed, as doctors, we assume that we can just divulge to anyone. We see a patient and the relative walks in and says, "Tell me, doctor, this is my brother-in-law, sister-in-law, my mother-in-law. What happened?" And we automatically, most of us would tell the relative what it is. So I think here, strictly legally speaking, we're not doing the right thing. We have to be sure on whom we are informing, and have we taken the patient into confidence, and do we have the permission to do so? And in all fairness, are we true to the doctor-patient relationship? And when the adult is incompetent, we perhaps don't face as many of these cases in ophthalmology. And in such cases, then you must involve the family members. So there are three types of disclosures that your patient can make when you can say that, okay, now I can divulge. So firstly, by consent, and that's self-explanatory. So let's go over that. And the second one is by the patient himself or herself. And the third is in public interest. So yes, if you have a system where you're recording the fact that this patient is now giving you permission to disclose, you are now no longer under the obligation of non-disclosure. The second one is a disclosure by patient himself, but not directly to you, not in a consent form. Like this was the Ashford Security Hospital in UK, a very important case that set the fact that if there is some information available in the public domain, made available by the patient or his or her party, then you cannot be liable for divulging this information to even a healthcare provider or the government or the insurance company. But I think this is a really important example. And I'm taking the example of epilepsy, but I think in ophthalmology, it would be really important for us if we know a bus driver has low vision or impaired depth or poor field of vision. Then this is in public interest. And imagine now he's a school bus driver, or even a public BMTC driver, whatever. Now, how do we go about this doctor-patient relationship? Of course, here I'm assuming that this driver is our patient. So encourage the driver to report it himself. Now, these are laws that got finally laid down also in the HIV Act, and I'm going to briefly end my talk with that, because that's a very great act for us to understand some of these nuances of divulging. And need to know basis. You cannot go around and tell the whole school and the children and the children's parents that, look, your driver has an impaired field. You should need to go and tell only those who can make that effective change. And finally, if you get sued for divulging, then what is the justification you have made, the rationale you have made, and so on. So this is a great dictum to remember, that personal privilege ends where public peril starts. They say your freedom ends where my nose begins. So something like that. The consequences are that a patient has a right to his or her reports. So when you are privy to, let's say, in coming back to the driver's example, a visual field which shows a 5-degree or 10-degree field, that is your the token of the obligation that you have to maintain, because that is a short proof, perhaps, that this patient of yours has a narrow field. So what are the laws currently that are governing us as healthcare physicians on what rules to follow in terms of the medical records? And I think this is best defined in the IT Act in 2000. The rules came out almost a decade later. I've highlighted in red the things from the act that are relevant to us. Passwords, financial information, yes, of course, but physical, mental, and physiological health conditions, as healthcare providers we are. Sexual orientation, not directly as ophthalmologists, but I'm sure we know where these cases will come. And of course, most importantly, medical records and history. So any of these we are responsible for in the IT Act. And of course, we are not responsible for what's in the public domain and if there is an RTI issue. We also must understand that confidentiality will differ based on the access we have for either outpatient, which is obviously easier because there are set number of records, or inpatient, where we now have to share those reports with several verticals, as we saw in the beginning. So this is an important slide in terms of what is the best way we can safeguard ourselves in the policy we will have to deal with these records, these reports, and therefore help us divulge or not all the records that we have of our patients. So firstly, it mandates, and I'm talking about the IT Act here, it mandates that every hospital or individual doctor should have a disclosure policy. So even whether you're a private practice or a group practice or a hospital, you must have this. And I believe that NABH makes this an important ingredient as well. And that policy should explain how the data is being collected through your EMR, through handwritten, through video recording, through audio video recording. And you can understand from here that clinical trials, biomedical research will come under all of this gamut. So if you're collecting personalized, sensitive data where a patient can be recognized, that would be a very important criteria. How are you collecting this? What are you going to use this information for? And when can it be disclosed? And what are the security measures that you have adopted in terms of maybe encryption, maybe storing it in safe places, maybe deleting it after it's required? All of that has to come in the policy. And you must get the consent that the person knows about these changes, knows about these ingredients of the data collection, and that should be recorded in a consent form, and you must have the access for. And if you have to share it to another hospital or maybe in a clinical trial registry, then you must ascertain that the group you're sending it to are also maintaining this level of data protection. Now, India doesn't have it, but the US has the HIPAA law. A lot of y'all may have heard this. And this is literally all of this. I'm going back to the slide. This is literally all of these 5 things. But one additional important point, and that is the time limit until which this data can be shared. And although we don't have it mandated in our act, it's probably a good idea. It also helps us to give a finite time period with which we can deal with the data, because the IT Act also tells you how many years you need to keep records maintained. if it's 3 years or 7 years for surgery or 21 years for a pediatric case, they are all laid down in law. So if you have the time limit also written into your data sheet or in your data protection sheet, it probably helps you better. And this is, an example from the HIPAA. And then there are special medical conditions. Again, not all of them, maybe some of them are relevant, perhaps because infectious disease, and I can think of uveitic conditions or other conditions that we are seeing. And these are specially recognized under the Confidentiality Act. I'm just taking an example from the HIV Act, and I'll read from the Act. Because this is where we can draw parallels to other conditions that we are dealing with as ophthalmologists. So no person shall be compelled to disclose his HIV status except by an order of the court, that the disclosure of such information is necessary in the interest of justice for the determination of the issues that are being challenged. And no person shall disclose the HIV status of any other person except with a written informed consent of that person. And these are the exceptions. These are the exceptions where you must divulge. So one healthcare worker to the other by the order of the court, or the fact that there's a legal proceedings, and this information is very essential. Statistics, but at that time you need to de-anonymize. So you need to anonymize the data, de-identify the data. And of course, if you are reporting to the National AIDS Cell or the State AIDS Cell. And when can you tell the spouse? When you think there is a reasonable risk of transmission. And just like in the bus driver case, you must first counsel the patient to actually go and tell the spouse or the next of kin, or in this case, the people whom he or she might most transmit the disease to. And only when you are fairly satisfied that this person is not going to tell is when you can disclose. So to summarize my presentation, confidentiality rests on the fact that the patient owns his or her information, both in terms of report and in terms of data, and the fact that the doctor-patient relationship is based on mutual trust and respect. It is no longer an academic debate. The fact that we have to maintain confidentiality is both our legal and, as we saw, ethical mandate as well. We now have a framework with the IT Act and rules, which gives us a decent legal background, and more importantly, on our day-to-day basis, how are we going to maintain our electronic medical records and our digital records? But at the end of the day, I think if we can have the good old days back where we counsel the patient and win their trust that we are at the end of the day for their better care, then I think there should not be any problem of either consent or confidentiality, or for that matter, any other case in the court. Thank you very much.
Thank you very much, sir. That was very enlightening and in-depth talk regarding the patient confidentiality. Now, I would like to invite comments from the panelists. I would like to first invite Dr. Prakash Marathe, sir, to give his inputs for this talk, sir.
So I must congratulate Dr. Anand Vinekar for the wonderful talk. I think he has been doing wonderful work in ROP. And as ophthalmologist, we know his work. But today it was a Medicolegal talk, and about confidentiality, probably he has covered almost all the aspects. Now, as he has covered each and everything, few little questions from my side and little bit of practical questions probably we'll discuss with Dr. Mathur sir also. First important thing is, as he has already disclosed, that whenever there are publications from our side, that is when the paper is presented or in the journal it is printed, I think about the identity of the patient, we must take the consent, and then we can disclose his photograph or his name or his disease. I think everyone should agree about this. And one should be careful for not disclosing his name and his disease without his consent. That is very, very, very important. Next thing is, as he has already said about confidentiality, it's the one place where it can be told to the court whenever the court is asking. I think, am I right, Dr. Anand?
Yeah.
Whenever court is asking that
Yes.
confidentiality, you need not keep confidentiality, and I think you are allowed to disclose each and everything.
Yes.
Next thing about HIV, it is very important. He has covered in a nice way, but practical tips that whether that HIV status of the person should be disclosed to his spouse or her spouse. Dr. Anand?
Sir, according to the Act, the short answer is yes. But the methodology of doing it would be first to talk to the patient and see if he can tell the spouse first. Then look at, you have to use your discretion in terms of his transmittability, what is his infective rate, and what are the chances that he'll give it to her if she's pregnant or they're trying to conceive a family. And I think with that background in mind, that's where the HIV Act says that there has to be, and the patient has to be encouraged to do it himself or herself, and if failing which, then you need to take the family into confidence.
Next thing about the tuberculosis, you rightly said that it is the report, this disease must be reported to the government authorities. The same way about pregnancy. I think there are few controversial facts in relation to pregnancy also, because you have to report to the government and confidentiality also has to be kept in mind. Like tuberculosis, definitely it should be disclosed to the government authority and the confidentiality about that patient is to be kept. And about pregnancy, there are controversial things, though it is the ophthalmology webinar. Probably few things you are disclosing to the government authorities, whereas it is said in the law that confidentiality should not be broken. What's your comment?
Very difficult question, sir. In fact, we are part of a WhatsApp group that discusses these difficult issues. I think the reconciling of the confidentiality aspects under the NMC and the POXO Act has created the maximum confusion. And a lot of gynecology colleagues, have this issue where, let's say, a 16-year-old comes to ask a gynecologist for contraceptive advice. Well, that automatically means that this person is considering having, sexual relationship, and this means that she's definitely going to be violating the POXO Act. Now, if you are privy to this knowledge, you're supposed to, disclose, but at the same time, there is the doctor-patient relationship. So this is where the difficulty comes. It's a little simpler when the person comes to you, simpler as in from a legal perspective. If there is a 17-year-old who's pregnant and the gynecologist has to now deliver and knows that this woman is 17, and again, a POXO violation, I think the way the law views a consensual pregnancy and a pregnancy from, let's say, rape is very different. And I think this is really beyond this conversation here. But these are very, very difficult questions in law right now, because the POXO Act has made one provision, and elsewhere we have to, the fact that consent is possible only after the age of 18, but then, consensual sex between 16 and 18 is considered okay from the previous, historical laws, is where the confusion is. So I don't think it's easy, and there's no straight answer. I think there you really need legal help.
Yeah. One important question about the insurance companies asking about the details of your patient. Well, there means reimbursement of the bills and everything. What is the limit? How much you should tell, what you should not tell?
I don't know the answer in terms of a legal mandate, but I think the idea is to provide only the exact amount of information that they ask. I'll give you the example in ROP, because we see that they ask a question whether this disease was there from birth. Right. The moment and of course we know ROP was not there from birth, but what they are trying to hint at is this a genetic condition? Right. The moment you say it's seen from birth. Because sometimes we may not think that week 3 of life is not birth, for us, a small baby. Now, by mistake, if you say, yes, it's there since birth, then this patient is not going to get a claim, because perhaps in their insurance premium, they are not covered for genetic disorders. So I think we have to, my point here is, I know I'm not answering your question directly, but my point here is we must know what is the intention behind the question, and we must divulge only that much information as is asked. What is the diagnosis? You just give the diagnosis based like exactly how the ICD would do it. What is the duration of the disease that you are seeing it? Well, if you are seeing this baby after the 3rd week of life and you don't know what happened in the first 3 weeks, don't comment. You say that you're in the 5th week of life, you say from past 2 weeks. So the point here is, no, don't divulge anything more. But you are again mandated to diagnose it, because otherwise you will be accused of falsifying data. You can't falsify data just so that the patient gets insurance. Classic example being, refractive. For example, sometimes a certain refractive power is considered not cosmetic surgery, and less than a certain power is considered cosmetic surgery. So if you give a higher power, just so that the person gets a claim and later it's found out that it's a lesser power, there'll be a problem. So these have been cases in court. So I think this is what I mean in A, don't falsify, obviously say the truth, but don't over diverge.
My next simple question, probably the last question before Dr. Mathur takes over. I think in Indian scenario, whenever the patients are being checked at OPD level, most of the relatives are sitting at and around. So really, it is not one-to-one conversation about the disease and diagnosis. In ophthalmology, it is not much a problem, but in other specialties like gynecology, obstetrics, and medicine and everything. So I think abroad, Europe and America and Australia, probably one-to-one conversation with the patient and doctor is possible. But here in Indian scenario, you can't ask the relatives to go out and sit. And unless the patient tells, then only you are going to disclose about the cataract or any disease for that matter.
Very true, sir. And we've seen this in inherited retinal dystrophies. We've seen this as when sometimes a child who is a preteen understands everything, and they can be shattered if you're telling the parent right in front of the child that this is very low vision and it's not going to get, if whatever insensitive words that we may use, it's going to be really bad. So we have to be from an ethical point of view, not even a legal point of view, we have to be very sensitive of how much information we give. And oftentimes in inherited diseases, what happens is, of course, there might be consanguinity, but this is where the mother will walk back inside the room after they have finished the consultation to give you certain facts that she did not disclose in front of her husband. So we must provide for that. And a very important point that we must deal with when we're dealing with, consider when we're dealing with inherited diseases is the whole in-laws situation. Because there is a lot of blame game in the fact that even in retinopathy of prematurity, where there shouldn't be a blame game at all, there is suddenly a blame game where the mother-in-law will say something to the daughter-in-law saying, because of you, the baby is gone blind. And God forbid you have to utter the fact that, you are a carrier of this genetic condition. It can break households, marriages. So we have to be very, very sensitive. It may not be as difficult like in psychiatry and gynecology and surgery, but we are also sitting on potential time bombs. And I think we have to be very sensitive of what we speak in front of the relatives. Ideally, we should just have the caregiver and the patient. If the patient is competent enough, we should have only the patient. Or you ask the patient, is it okay if somebody else comes? See, in my field, in pediatric retina, baby is always going to be called, accompanied by the parents. But I always ask, for me, the mother has to be in the room. And then I ask her, do you want to bring someone else? And sometimes it's not the husband. Sometimes it's her mother, and sometimes it's her sister or even her mother-in-law. But I think that autonomy we have to give the patient, or in this case, the parent.
Thank you. Thank you so much. Over to you, Dr. Dipansh.
Thank you, sir. That was a very good discussion. I would like to invite Dr. Mathur, sir, for his comments.
That was a wonderful exposition, Dr. Vinekar. So basically, he highlighted the subtle difference between privacy and confidentiality. That was a good thing for all of us to learn. And what I found among the medical fraternity, especially in the other specialities, like just to console the patient, the doctor has a tendency to take the names of their relatives. Oh, please don't bother, though it may be in good intention. Oh, please don't bother about this condition. He or she also has that thing. So that is a real breach of confidentiality, and that every clinician, like as a slip of tongue or whatever, we are not supposed to disclose the diagnosis of other the people that your patient knows about them. So that is a thing. And he has highlighted through all his slides the legal aspects and the social and medical aspects as to what should be documented and what can be revealed, what cannot be revealed, especially on social media and even in our clinical presentations, is the name, age, and sex of the patient. Like, I practice glaucoma. I see so many cases where the field reports are there shown, OCT reports are shown, but care is not taken to blank out the name, though it may not look very distinguished like thing, but we are not supposed to. We are not supposed to reveal the identity of the patient. Especially, you can take photographs of the eye, or the two eyes together, but certainly not the entire face should not be revealed unless you have the consent of the patient, and even under medical supervision, and even among your peers, among your academic groups also, we should take that precaution not to reveal the identity of the patient unless you take a explicit consent from the patient to reveal it. So regarding collection of data, though you are entitled to record the personal details of the patient, but that is only for you. And when you are publishing these data, you have to publish only the medical condition, the statistical analysis, and all those things. And the data, personal data, is only preserved as a confidential data, and only on inquiry by certain agency, if they want to really check out on the data for your paper, only under such situations you can reveal that data to the concerned authorities. So all in all, a very interesting and very nice presentation by Dr. Vinekar. So thank you very much and all the best.
Yes, sir. Thank you.
Thank you, sir. So, sir, sometimes it becomes difficult. Actually, sometimes the only relative or the only accompanying person is a distant relative, and probably it becomes difficult to send them out. Or the patient is also not in a condition to send them out because he or she is the only person accompanying them. So, do we still ask them that is it okay to disclose the findings and diagnosis to the patient, or can we go ahead with it, sir?
Probably you have to exercise your discretion. What is to be revealed, what is not to be. You have to be, you can just give a hint to the patient, like, okay, not to worry, this is a thing, but it is not so this thing. We will be starting the treatment, and we should try to beat around the bush. If you think that the disclosure of diagnosis, especially uh, in the presence of a distant relative, unless you have explicit consent about the patient, and probably like Anand, how it is like these are very delicate situations. Probably if I am there, probably I would like to beat around the bush a bit and see if you get the pulse of the patient. You can just observe the patient. The patient will be nervous. If the patient demands, yes, doctor, what is it? What is it? Let me know. That is probably in that situation, probably you can leak out information slowly. But as much as possible, exercise discretion, because disclosing the diagnosis to the relatives, it can spread like a wildfire among their community.
I think I'll add one thing here. Breaking the news, probably when it is the bad news for the patient, sometimes we are tempted not to tell that thing to the patient, but to the relatives, so that it should not be a bigger shock to the patient. So in that case, we are diverting a bit to save the patient's mental status, and that way we are telling to the relative, but that is for the betterment of the patient.
Sir, I just want to add here something. If in case a patient is bringing a relative with him in the consulting room, does that indicate that the patient is already comfortable with the relative? I mean, is it assumed that, okay, fine, maybe uncle or aunt who might be a caretaker or who might be the accompanying person the patient is comfortable with? Still we think about or just disclose
It's more
partly?
like an explicit consent. You can take it in that way. It's a sort of a explicit consent that the patient is coming with somebody. And many times it does happen, like when you are going to examine the patient, when you're getting up from your desk and going to your slit lamp or your workstation, the attendant certainly tells you not to divulge the details to the patient. And like, even in such situations, there are situations like the attendant may request you not to divulge the diagnosis to the patient. So it all you need to exercise your discretion and go ahead.
All right, sir. Dr. Kaushik, do you have any question?
Sir, what are the implications if you have a camera in your like examination room?
Chamber.
Is it allowed? Or like what are the considerations here? If you have like a CCTV camera in your examination room, is it allowed?
So I can say that because we have been, exercising this where patients actually, the reverse is also, they come and start recording your conversation. So we have actually put out boards outside that you can record audio or video, but after the permission of your doctor. And not doing that is a violation of both the doctor's privacy and his or her. So similarly, we also have to, you would have seen in malls, this area is under 24
The
hours
CCTV.
TV coverage. So I think it's very important to make that mention, that they are aware that they are being, it's not also so much that what they are saying is getting recorded, but they may have a private moment, they may be, adjusting their clothes or tending, feeding the child. So all of this has to be, and there have to be sensitive areas where cameras are just not allowed. Example being a feeding room, or of course the toilets. But if you are going to put a CCTV, and I think, because of violence against doctors that became such a big topic a couple of months and years ago, that a lot of places have put cameras. But I think by mandate, we have to mention that that area is being recorded.
May I interrupt here? I think in case of fields like gynecology and obstetrics, whenever you are chit-chatting with the patient, asking the history, or consultation is going on, probably you can put the camera. But whenever it is a physical examination in that room, cameras has to be avoided. Though in ophthalmology, it may not be possible. You can put cameras whenever you are checking also. But in the fields like gynec obstetrics, checking area, the CCTV should not be there.
Physical identity as well as the modesty are the terms that you must take care when the identity of the patient and the modesty aspects of that thing should be taken into account, especially for this.
If there is no question, one important thing we will revise here with the help of Dr. Anand and Dr. Manoj Mathur. I think OPD records, then indoor records, then child attaining 21 years of age, that type of record, income tax records, and routine records. How much time we should keep those records? I think, if I am not wrong, OPD and indoor, there is little confusion, but 2 to 3 years for OPD, indoor for 5 years. Then if it's a child up to 21 years of age, and then if it is a medical legal case, maybe 30 years or lifelong. If it's income tax, about 7 years. Correct me if I'm wrong. And one important thing is routine documents.
8 years for IT. 8 years for IT. Generally
7
for
to 8 years.
OPD records,
7 to 8 years.
Yeah, for OPD records, they say 3 years, but to be on the safe side, 5 years. But this doesn't absolve you of the medical legal aspect.
Exactly.
So basically, if you think that this is a potential medical legal case, you need to preserve it forever. And 8 years, 5 years to be on the safe side. And OP indoor record, they generally say about 7 to 8 years. Similar to that.
Now the question comes, whenever you have disposed those particular records with these particular guidelines given by the law, and some medical legal case arises, or some document is asked by the government authority. In that case, you have already destroyed that particular document. Now the question comes, you don't have that document. And in that case, can you answer? Can you answer?
Yeah,
because
you do
by
have
law,
immunity, sir. You do have immunity because the CPS states that your case has to be filed within 2 years. So generally after 2 years, unless it is a gross case of negligence or gross defect that is noticed at a later date, under such situations, you can be the Consumer Protection Act, they generally don't admit such cases. So even in the civil cases, that thing is a remote possibility. But if it turns out to be a criminal negligence, then the court may permit or admit that case. And in that situation, probably if it is an indoor case generally, so after a lapse of 7 to 8 years, then probably you do get some concession from the court.
Okay, thank you.
Do we have any more questions or comments from any of the panelists, speaker, or team members?
Dipanshu, I would like to ask something.
Yeah, please do.
So I just want to find out, is anyone aware of any case, medical legal case, which has happened to any of our ophthalmologic colleague regarding the patient confidentiality till date?
I'm not aware of.
Basically, I'm not aware of.
No one knows. Means it is not yet heard.
We only discuss among ourselves. We criticize each other for exposing the patient's identity on the WhatsApp group. Apart from that, I don't think any patient has complained about it. But if patient confidentiality, it does affect them, especially if their known people, if their known relatives or their friends get to know about their condition specifically, they may have objection. If their condition is exposed to the peer group or the doctors, academic groups, without their knowledge and without being informed about them, probably most of the times they are unaware of it. But even if they are aware, uh, if the doctor says that it was in the medical condition that we were discussing just about your case to help you in a better way, probably there may not be an issue, but you never know. Like if patient thinks that he or she can squeeze out something from you, then you have it.
Like in case of live surgery and deferred live surgery also, whenever you are operating the patient, probably the identity is disclosed. But beforehand, you should take the consent from the patient that your surgery will be telecast and people will be seeing your face, maybe type of surgery which is being done. So that type of consent has to be taken beforehand in case of live surgery as well as deferred live surgery. That's what I think.
Arti, I know of like a paper which was retracted. It was not written by like ophthalmologist, by dentist, but on orbital reconstruction, like something like some orbital prosthesis, etc. There was an image of a female, and the author said that yes, we have taken permission from the like person, but it was actually not taken. So that person actually contacted the journal and it was retracted. So this I know, like if you send a photo specifically, as Manoj sir said, where an image from which the face can be identified, and if you do not take explicit written consent from the person, if they complain to the journal, then that article can be retracted, and which is an academic misconduct, and obviously the authors get defamed for that.
There is
The
a fact.
hospitals that I work, like they have written as a footnote. I want Anand to comment on this, whether that is a good thing or legally a thing or this thing. The findings seen by us or examined by us can be used for clinical trials without using your personal confidential, maintaining your confidentiality and something like that. Is that justified in an OPD sheet?
Generalized, no.
No.
It should be specialized. Means
So
pertaining to
it
that
should be
particular person.
specific.
That's what I mean.
Yeah, just a line is mentioned. This data may be used for clinical purposes without revealing your identity. So
Dr. Anand can answer because you asked him the question.
I'm not sure of the exact legal position, but truly, as what Marathe sir said, that a consent for publication will have to be standalone. But putting a line here saying that, taking the consent for all the examinations that you do, and the part that part of your information become anonymized data, if you put it into the standard consent, there's no harm. It gives you one level of safeguard. It's not foolproof. But if you are absolutely sure that this patient is now going to get published after, even in hindsight, you can go back and you should ideally take a special consent.
Next question from my side. One practical question. You know the girl where LASIK is done, she had -8 of myopia. Now, you know the boy who wants to marry to her. And you know about the refractive status of the girl. And that boy is known to you, maybe as a patient or maybe family relative. What should be your say in that case as ophthalmologist?
I'm
Time we
hoping
won't be doctor.
for me.
Both, all of you, for that matter.
Okay, so in this case, I think it's fairly clear, sir. This is an adult patient who is now going to get married. So one must ask the patient whether I mean, you said girl, so whether she's willing to divulge that information. It will also be in good, good patient building confidence to tell the girl that it might be a good idea for her herself to tell rather than we tell the boy. Because at the end of the day, one is that he wants to marry her. The second thing is she's going to probably produce myopes if he's also a myope. So I think it's very important nowadays that we, instead of matching kundalis, we match our genetic and our
certificates.
thing. So I think if we encourage her and tell her the importance of it, she herself will tell.
Good.
But no, I would not divulge it to the boy without the girl's consent.
Okay.
Right. If we don't have any other questions or comments, with the permission of panelists and speaker, can we close the session?
Yeah.
Thank you so much. Thank you.
All right,
Thank
thank you. On behalf of YOSI and YOSI Medical Legal team, I would like to thank all our senior panelists who have been the constant guiding force in this MLC series since past 2 years. And for today's session, I would especially like to thank Dr. Anand Vinekar sir, who has managed to take out time for this talk in between yesterday's match and his following week's busy schedule. Thank you very much, sir, for taking out time for this talk and covering the topic so well. It has enlightened us definitely and probably help us out in shaping our clinical OPD better, so that we can avoid medical legal cases. We have completed 29 sessions, hoping to see you all for the next session. Thank you. Thank you, everyone.
Thank
Good
you.
night.
Thank you so much.
you, sir.
Good night. Good night, everyone.
Thank you.